And it is week 7 already. It's going by quick. Remember, next week is already going to be exam 3 reviews. Now, I have a question for you all. Thursday at 4 o'clock, is that a good time for you all? Or you tell me, give me a time, give me a date.
We get done with clinicals, they said at 4. So afterwards,
5, 6?
like 5:30, that'd be fine.
Well, and then we got class at 5:30 on Thursday.
Yeah, me too.
All right. What about Wednesday? What about Tuesday? Well, Wednesday, there's already a review going at 5 o'clock, I believe, which is Professor Luminoso. So Tuesday,
I don't have class.
And Friday, I teach all day.
Yeah, we're in class in Cincinnati all week, and we have clinicals on Thursday. What about Sunday?
You want to do a Saturday or a Sunday?
Please.
Sunday's my only day.
Sunday we'll be at clinical, so.
Oh no.
What time?
What time, y'all? Is it 7 to 6:30?
Oh, you're like that late shift.
7 a.m. to 6:30, yeah.
All right. What I want you to do in the chat box, everybody, give me a day and give me a time. Afternoon, morning, night. Tell me what you want. And I'm going to look at that and I'm going to pick the most.
What days do you teach? You said during the day?
I cannot do Friday. Everything else can arrange around your schedule because students are always number one. I mean, I have meetings all the time that I do, but if I'm doing something for students, you are always number one. So in the chat box, when? I'm going to give you 2 minutes.
It's disabled right now.
Oh, sorry.
You said Professor Luminoso's is Wednesday at 5?
Wednesdays at, hold on, let me be sure.
I know a lot of people from my class might not be on the roster for showing up, but we always watch the recording.
Oh,
I don't think there's one
that. With mine, I'm in YouTube, so I see how many times. There's like almost 200 views, when we go into exams. I know you're watching it, but I also know sometimes it's nice to be that person who's there, who has a question, who can ask. And I do know that. That's why I'm asking, what do you want? Now, we do have Saturday, 10 a.m., Professor Stiles doing that, and 6 p.m. on Wednesday, Professor Luminoso.
Okay.
I usually would do it Monday, but it's Memorial Day.
Let's do Tuesday.
Tuesday, what time?
Anytime, I guess the most people is available. I don't even have class on Tuesday.
We have class on Tuesday in Columbus.
We have an exam on Tuesday, but we could do it after.
What time? What time? What time is the exam over?
We evening classes, so we go, what is that, 4 to 6:30?
Y'all want to try to do 3?
You want to do 3 o'clock on Tuesday?
No,
we have
at work.
I'll be at work. I go straight from work to school.
I mean, I can't please everybody. I know that. But, so Tuesday sometime would be good, or Thursday?
Tuesday.
Tuesday better than Thursday.
Tuesday.
Yeah.
For Columbus, Thursday is better. Tuesday doesn't work for us. We're in class from 5 to 11.
Okay. All right. I'll talk to the lead and find out when it works in with her also, because she has things going on too. So as soon as I get it, I'll let you all know. But I'll be doing it sometimes next week, and I'm going to have everything recorded and it'll be there. Also, those who are on that little cusp of border, close, please, please, please meet with me before exam 3. I can help you understand those concepts and help you get your grades you want. I don't need a lot of your time. I just need for you to get with me and we can discuss those big things that you might say and make you understand it easily, okay?
I had a question.
Sure.
With Monday being a holiday, this my question is to all of my classmates. Do you guys have class? I know Columbus, we don't have class because of the holiday.
No, no online has class on Monday.
I got a question.
No online
We got a
courses.
quiz next Friday.
All right, that's my next thing. No,
I
you
got a
do not have a quiz next week. Happy Memorial Day weekend. And the reason is because we do have a Monday class, 2 of them. So we're not going to give that and give you, it's not fair. So you on week 9 have an exam. So your quiz will be week 10. Okay?
June
So
14th.
yes,
Long.
quick question. With the
Sure.
HESI reviews that you guys do they record those?
absolutely everything is reviewed. Everything. Yes,
So
recorded,
do you
yes.
so with the quiz in week 10 be from material from week 7?
It will be from week 8,
8.
Okay.
8, 9. I will get
Eh,
back to you,
Okay.
give you the exact. And of course, you'll get your worksheet that you'll know what to study.
Can you
Okay?
make an announcement with the HESI recording link in it? Or is it already out there?
No, I haven't put it out yet. What I do starting after week 9 exam, our material's really done. And I start doing HESI reviews. I start with some big cahoots. And then on week 10, I am doing your NCLEX book, your PN NCLEX Saunders book. I've gone through it and made a PowerPoint on everything you need to know. So I'll be going over it, explaining it, try to make it so that you understand it and that you can recall it when you need it. When I did that 2 quarters ago, I had students tell me it was spot on. They saw everything that was there. Now, yes, it is 80 some odd slides. It is a lot, but we've covered it all. So it should be a refresher. I know it's not. I know it's a lot to know. I do. But even with it, I've seen the HESI scores improve a lot with using that. Okay.
We'd rather be over prepared than under prepared
Oh,
over here.
absolutely. These are always, all of your bane of your existence. They are difficult. I also do, I call the all nursing HESI Q&A. I combine RN and PN together because you guys do the same thing. PNs have always been my ears, and PNs taught me to be the nurse that I am today. So I know if I explain concepts to either PNs or RNs, you both think the same. So I do according to what HESI results have showed me, what type of concepts you might see. And I go over system by system by system. And I do that on week 10 on a Saturday at 2 o'clock before week 11 HESI. So you guys will have a lot of HESI preparation. You will not be underprepared, okay?
I got a question. So do we come up to the school for the HESI?
All your HESIs are on ground at
Yep.
school and you sign up there.
Okay.
I have a question.
Sure.
Can you post yesterday HESI review? I tried to join yesterday around 5:20, 5:20, but I think it was over already. And I didn't see it on Canvas.
Okay, I didn't get it. Let me get to Professor Stiles and I'll
Okay.
get it posted. Clara, I've already reposted your Kahoot. So that I've already done. So what you need, I'll do that now. I think another thing I'm hearing is that you'd like to see the SE review PowerPoint early so that you could start printing it, looking at it, studying it. And it doesn't hurt studying the areas we're going to be having a test on. So I'm going to send that out and I will do that next week so that you will have it. Okay. Give it to you early.
Okay, I'm sorry. What about Hesi Kehu? You gonna post that before?
I can do all of them, whatever you want,
Okay.
Hawa. Not a
Yeah,
problem.
that'd be good because
I'll
that
give you
one
it
is
all.
so long, so we can try to practice before.
Not a problem. All of
Thank
those
you.
things, whatever I can do to help you all succeed and do good on the HESI, absolutely. That's always
All
my
right.
goal, that you
Okay,
all go
thank
to the
you.
HESI and go, oh, you can hear my voice and you know what the answers are.
Thank you.
You're welcome.
And if we want to meet with you before the exam, should I just message you on Canvas to
Just
set up the
message
time?
me, absolutely. And we can go over, the review, what you don't understand, make it understandable, and making sure that you do the best you possibly can. Not a problem.
Thank you.
I mean, if you want to meet with one person, 5 people, it doesn't matter. Whatever works for all of you. I know some of you at the same campus. I've done 3 people, same campus. Whatever works. So this week we are going to be going over your blood and blood forming organs and GI. Remember, there is a discussion question and there is a CJ Sims. Now, you all did get your last CJ Sims in. Make sure you do. I'm telling you, CJ Sims are the highest percentage of grades, 5% for each one. So I was like grateful everybody turned it in because it does make a difference. And I've seen a student not be successful because she didn't get a CJ Sims in. And I don't want that for anybody. That's why if you hear a message from me, I'm getting concerned, I'm getting worried, okay? Not because I just want to be a pain. No, I want to help. All right, let's start with blood and blood forming stuff. And we always know we have objectives, and let's go from there. Now, the lymph system is part of the system that supplies antibodies and it destroys well, right? So we know that if we're seeing swollen lymph nodes, we know something's going on. A child does not have lymph nodes that are visible or palpable unless they're sick. So it's where infectious organisms are destroyed and the antibodies are made so that we can, if it comes again, be prepared for it. Now, the spleen is the largest organ in the lymphatic system, and it brings blood with the lymphocytes, and it gets bigger because when it has an infection, because it needs to, make sure that it takes care of what's going on. So the spleen is a really big component of fighting infections.
Mhm.
Now, blood. What is blood? It's a whole bunch of stuff. It's not just red blood cells, there's a whole bunch of things in there. It has the liquid that holds all the blood cells, it has erythrocytes, red blood cells, it has white blood cells, which fight infection, and we have platelets, which help with blood clotting, right? The red blood cells are interesting. Now, red blood cells comprise of the hemoglobin and hematocrit, right? What does the hemoglobin or red blood cells, erythrocytes, do? Well, what's important is they carry oxygen around to the tissues, to the body, to the organs. It also carries iron and nutrients. So the red blood cell feeds the body, what it needs to keep it strong and healthy. That's why we're concerned about those anemia. You're not getting enough oxygen or nutrients, right? Now, lymphocytes are that fight infection. So, you get a cold and your body immediately has antigens and antibodies that starts to say, nope, go away, I don't want you. And then lymphocytes, lymph, which means lymphoid tissues, are something else that helps fight against infection. Now, anemias. I mentioned it slightly just now. Now, what happens and why do children have anemias? Well, again, the problem with anemias, excuse me, is that if you don't have enough red blood cells, you're not carrying enough oxygen and nutrients and iron to the cells, and the body doesn't have it. What happens when you don't eat? What happens if you don't give nutrients? You're weak. You can't do normal activities. You have to sit more frequently. Infants are not able to eat. They won't gain weight, right? So anemias are really important. They say that a hemoglobin below 8 means that the body is trying, by elevated heart rate, try to pump things around, but the organs aren't getting what they want. Now, what would you see with anemia? So the body wants to eat, it wants its oxygen, wants its food. So it says, oh, let me just beat faster. Let me get this stuff around quicker. And that overactive heart could lead to heart failure. So we're worried about that. We're also breathing faster because you breathe to get oxygen in, right? So you're tachypnic, you're tachycardic, and then because then your heart says, I'm getting really tired here, you go into congestive failure. Fluid builds up into your lungs. Now, iron deficient anemia, most common of all the anemias. Just think about toddlers. When they're less than a year old, we are giving them breast milk. We're giving them iron fortified formula, iron fortified cereals. We're giving them extra iron. Well, what happens when a kid is a toddler? All of a sudden, they're like finicky. They don't want to eat these things. And then we switch them to whole milk. Whole milk does not have iron in it. So a very common group of children that leads to, anemia is your toddlers because of that finicky eating and because of drinking just cow's milk, okay? What do you see with iron deficient anemia? Well, of course, they'll look pale. You'll see inside their gums sometimes, tongue, sometimes even their ears look pale. They're not getting oxygen because there's not enough cells. They're irritable, right? And then they're so tired, they become anorexic. Also, they're not going to be as active as normal. I mean, think about toddlers and preschoolers. They're busy, 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 busy. Well, they don't have oxygen. They don't have iron. They don't have fuel for the tank. So they have this decrease in activity, okay? Now, how do we diagnose this? Well, as simple as a CBC, looking at the red blood cells, looking at hemoglobin, hematocrit, and of course, looking at what is their iron levels. Now, one of the things we have to remember, don't always assume it's an iron deficient anemia or something else, because what else causes loss of blood and not enough? Simple old GI bleed, right? So immediately, kid looks like they're, their hemoglobin hematocrit's low, they're tired, all the symptoms are coming up. First thing, test their stool for occult blood, rule that out, then try to figure it out. As I said, the body really wants to get its oxygen, really wants to get its iron and nutrients. And the heart beats, and nothing's happening. It's like running the mile and you could, continue to run. You just tucker out and tire. Well, that happens with the heart muscle too. And when it becomes too weak, that's when the fluid starts building up, okay? Also, children that don't have, enough hemoglobin hematocrit, they're not getting oxygen nutrients. What happens? Well, remember I always said nutrition, nutrition, nutrition. Cognition. Their cognition's going to be delayed. They're going to not meet their, mile markers on their growth and their development, and they're not going to grow the way they should. And it's one of the things that we would look at. We saw a kid that's not doing all the developmental things they're supposed to, that they're not gaining weight. Simple CBC, we're going to look at it. So how would be the first thing that we would do to treat iron deficient anemia when we determine that's what's going on? Well, we're going to give iron, and it is a liquid in children. They're depending on the age of the child is how you give it, but iron needs to be given through a straw, and it needs to be followed with orange juice. Also, it should be on an empty stomach. Iron is broken down and used by the body with it going to the stomach, and stomach acid breaks it down for it to be used. So never with milk, never after you eat, always before. And we give orange juice as extra acid to help it break down so it's used a lot better. That's why it says vitamin C aids in absorption. So some of the ways that we prevent iron deficient anemia is that for the first 6 months, we know it's iron fortified formula or it's breast milk. We know that that helps keeps the irons up. Now, after that, we're figuring out what's going on. And we start this child on those iron supplements. Remember that the stool is going to, it's like a black, green, sticky sort of stool. If you can imagine having a child, normal stools, you give them some iron, and all of a sudden their stool changes to black. If the parent isn't prepared, they're going to be really scared, right? So always make sure we teach this. Also tell them never with milk, do it before meals or 2 hours after because we need that stomach acid. And of course, with orange juice is the best. So during a routine clinic visit, the nurse notes that 18 months old has pallid skin, appears lethargic, and is overweight. The mother says the child's become less active and increasing irritable. What condition should the nurse suspect? What patient education do you need to give? So what do you think that is? It's a toddler.
Anemia.
Absolutely. And why is it anemia? Why did I say?
Say the question again.
Why are they becoming anemic at 18 months old?
Because they're being switched to the whole milk and they're not getting the proper nutrients and iron.
Absolutely, absolutely. It's that whole milk and the finicky eaters. I mean, toddlers, all of a sudden, they have taste buds and they don't like this, that, and the other. And as infants, anything you put in their mouth, they'll eat, and all of a sudden, not. And the education, again, if they're older, trying to incorporate iron-rich food, right? And also tell them about iron administration and what they might see and how to give it. So sickle cell disease, very common African American and Mediterranean population. Sickle cell disease is red blood cells that are born in a sickle shape. And you can see the picture here. And the problem with it is your cells are formed, but they die quickly. They're, so they're very short life. So your hemoglobin and hematocrits are extremely low on these children. From all the career that I've had with sickle cell, your hemoglobin and hematocrits, if they're 7 and 21, I'm happy. I usually see actually 5 and 6, which is very low. So what causes sickle cell problems to go on? Well, the destruction normally, so decreased oxygen. And sickle cell is caused by it gets clogged up in the vessels. So sickle cell, the vessels itself, yes, you're anemic, you're tired, all of that. But then it gets clogged up in the vessels and causes a lot of pain. Sickle cell crisis. So what happens is you have a vessel and it bifurcates into two. And usually at bifurcation, especially with dehydration or you're in an airplane, you're in high altitudes, we're compressing, atmospheric pressure, the vessels become small. And that sickle cell cannot get through. So it gets clogged. And the next one clogs on top of each one. And there's swelling that goes on. And then below, it's not getting oxygen, right? So now you have, death of tissue down there. So dehydration is a big thing. You need to keep really hydrated. Also, think about infection. What happens with infections? You get a fever. What happens with fever? You lose fluid. So, again, dehydration and stress. And if you can imagine exposure to cold, what happens when you get cold? Your vessels constrict, right? So, there are two types of disease. There's a trait and there's a disease. What you need to know is if two parents have just the trait, every child has one chance out of 4 to have sickle cell disease. So it is hereditary. Now, what do you see with sickle cell? Usually we don't see anything till when they become toddlers, okay? And then usually what we're going to see is those sort of sickle cell crisis where the hands swell up, the feet swell up, or an enlarged elbow. Something's going on, or the kid's complaining of pain, holding something and crying because it's swelling, it's hitting nerves, it's stretching, and below it's not getting oxygen and it's dying, which is causing also pain. So as I said, these kids do have low hemoglobin hematocrit because these cells, yes, they're produced, but they die really, really quickly. Sickle cell crisis, they come in and they're in pain. Now, it could be anywhere. You have vessels everywhere, in the eye, in the head, in the chest, everywhere. So, knowing a kid has sickle cell crisis, they complain of a headache. Guess what your concern is going to be? Maybe a stroke, right? It could be in the eye, which could cause loss of vision. Could be in the chest. Could look like a pulmonary embolus. They're very, very painful. So where the child complains of it is what you and how you're going to give your nursing care. If they're complaining of a pain in a knee, well, how are you going to help that child? You're going to give fluids, you're going to give heat to dilate it, and you're going to give something for pain. Try to open up the vessel, let those cells go through. So now you're stopping the reason for the pain, okay? You just don't give pain medicine because the cause is still there. Your vessels are small. Let's dilate them. So Raymond is a 16-year-old admitted to an adolescent unit presenting with a fever, joint pain in his knees, shortness of breath with exertion, and fatigue. He told me he's stressed out, not sleeping well. He was diagnosed with sickle cell at 6 months old, and his parents are extremely vigilant in his care. He has only been hospitalized 3 times since his diagnosis, one at 9 months for the diagnosis, stabilization, and then at 5 years old when a thrombic occlusion crisis while having pneumonia. His third hospitalization was at 13 years of age and oral chelation therapy. What is chelation therapy? It's the removal of that iron from those cells that are bursting in the body. Not uncommon with sickle cell or thalassemia, which is part of this. Throughout his school years, he was treated with penicillin prophylaxis, usually 1 a day, and home oxygen saturation monitoring. The home oxygen was only needed to prevent hypoxia. Pain has been managed with acetaminophen and acetaminophen with codeine. He's received periodic transfusions and red blood cells exchanges as an outpatient. He's required several blood transfusions in the last 8 months, and the most recent one yesterday at outpatient center. He is here now to manage a vaso-occlusive episode. So what do you think that this kid needs first? Walks into the ER, he's having an episode. He comes in. and he's complaining, let's say, of that pain in the knee. Well, number one, we want to give him some fluids, right? And we want to give him some pain medicine, put some heat on it, and of course, draw the labs. And if we need to, most of these children will end up getting some sort of blood, though he just got it. So thalassemia, as I said, was very similar to sickle cell. What's the difference? Well, I call these rectangular shaped cells, okay? This is hereditary. And these are a lot of people that are Mediterranean descent. You know, we have African American, which sickle cell that we see a lot, some Mediterranean, but thalassemia is your Mediterranean. And these red blood cells, they're formed. The spleen works, blood cells are formed. But again, these explode, okay? And when they explode, what's in a red blood cell? There goes your oxygen. And there goes all of that iron going into the body, which can become dangerous. So there's actually two types of thalassemia. There's a minor one, and usually when we're testing on these things, we call it a thalassemia major, okay? Or Cooley's anemia. So thalassemia major is that bursting of cells like crazy. The body can't keep up with it. The cells that are formed are still going to burst. So the body is lacking from oxygen and having too much iron in the body. So, because they don't have cells, they're pale, they're hypoxic, no oxygen, right? No appetite, their fever, their jaundice, their spleens are enlarged. And a lot of times you see these facial abnormalities, sometimes protruding cheeks and jawbones. It's just part of, what they look like. Like when you talk about a Down's child, what they would see. A child with thalassemia also have these different body looks. These children with Cooley's anemia must get blood transfusions. They can't just get iron or something or eat better. Their cells are dying. The body's not making cells. So they're getting blood transfusions. Whether it's weekly, bi-weekly, twice a week, it all depends on the child. Now, when we think of bleeding, we think of hemophilia. We have factor 8 and we have factor 9, the two big ones that we talk about. And it doesn't matter. It's all part of, you need these sort of things in order for the blood to clot so you don't bleed. There's all factors. There's even platelets, right, that help you with bleeding. Now, hemophilia is an X chromosome hereditary that we give to the child, okay? Any missing factor will cause a prolonged bleeding time, whether 8, 9, there's also von Willebrand's and platelets, doesn't matter. Now, some of your children don't bleed as much as others, and some bleed more. Remember, if they're bleeding, we need to stop it. Or what's going to happen? They're going to lose all their blood. So we need to do something to help. And what we would do is we would give back that factor, whether it's factor 8, whether it's factor 9. And, one of the ways that we check, is it working? Well, what are one of the blood tests that you do that looks at bleeding coagulopathy? We have a PT, prothrombin, that's for Coumadin. But what we check in hemophilia is the PTT, the partial thromboblastin time. And it's usually quite elevated. So just like you gave too much heparin, this child is going to bleed, 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 bleed. Now, sometimes we have that understanding that they're hemophilia, at birth. But usually it's about 3 to 6 months when their own cells are being formed, and then we're going to see that there's a problem with it. Okay. We're looking at, birth, and we're looking at blood clotting. It's usually 3 to 6 minutes, and then we have the bleeding stop. In hemophilia, it would be much prolonged, but not exactly at birth. So what do we see with hemophilia? Well, you're losing blood. You also have leukocytosis. The body's trying to help. Why are we losing all this blood? Remember, the body tries to help, makes more platelets, but it still needs that factor. It's still not enough. You're going to see blood in their urine. And we know if it's bleeding, we hit our head and it's bleeding in the brain, we know that we could die from that. And if we're seeing a child with hemophilia complaining of headache and then vomiting, which is showing you pressure, this is extremely serious. So, parents of a 9-year-old boy are confused about their son's diagnosis and treatment for hemophilia A. They don't want to excessively limit their child's activity, but they're concerned about how to prevent bleeding and how to treat it if it occurs. What information would you give? So, let's say this 9-year-old's outside playing with his friends, falls down, hits his knee on a rock, and now it's swollen and it's ecchymotic. How would you treat that? Oh, and he cut it too. So you have a kid who now is very upset, bleeding, very anxious, heart rate goes up, blood pressure goes up, they're bleeding more. So, number one, calm them down. So that's the rest. Then you want to do the rice, right? You want to vasoconstrict those vessels, decrease the amount of blood coming out. And you're going to put an ACE bandage and you're going to elevate it. And at home, they're going to give the home therapy. They can get factor 8, factor 9 at home. I've seen parents do it and do it really well. So, hemophiliac, especially, bleeding into joints, that's caustic. It's going to cause joint damage. So we want to stop it as soon as we can because we don't want to make them crippled because we didn't get that bleeding and that they didn't know how to stop it. And now the child ends up in a wheelchair as a adolescent because kids play. They're going to fall down. They're going to have bruising, right? We're trying to decrease it as much as possible. Now, another thing that has to do with bleeding is your platelets. So, platelet disorder, when you don't have enough, is called thrombocytopenia. And usually we see severe thrombocytopenia. You'll see platelet counts 20,000 and less. It's really, really low. And usually they come in two things: nosebleeds, epistaxis. There's no all of a sudden they're sitting there and their nose starts bleeding. Or all of a sudden they see this petechial purpura rash type thing, and then they're seeing bruising, hematomas, ecchymotic areas. And the mother says, this kid plays his games all day. He never goes out. Why are his legs full of this stuff? That is the hint. So they think it has to do with a viral infection that happened previous to the platelets dropping. They're not sure, but they really think that's what it is. So what they do is these platelets, the spleen destroys them, and you're left with these low counts. They say it's somewhere between 2 to 4 that we see most of them. And again, those are the purpura, the petechiae, and all these things. That is, they say, the recent history of rubella, rubeola, virals. And again, I told you platelet counts are 20,000 and low. They say that the diagnosis is that bone marrow aspiration that they'll do to look at those cells. So how do we treat it? Well, always with any bleeding coagulopathy, our concern is bleeding in the brain. That's number one, okay? So neurological assessments are very important. But we give prednisone, steroids, IV gamma globulins, and we give anti-D. Now, usually they say with ITP, if we can get it under control within 1 year, that's an acute and we can cure it. But there are times where it becomes chronic, which means over a year of having it. They might take out the spleen because the spleen produces platelets, right? So they take it out and they say that that helps. With any bleeding coagulopathy, you have to know what to avoid, right? You don't want to have anything that causes more bleeding. So aspirin is number one. Furthermore, they should be taking it, but we need to mention it. And, these other things also, caffeine. Now, one of the things we try to do with children with bleeding coagulopathies is we want them to be normal. We want them to play, but we have to be selective in what they could play at. For instance, a child in an acute stage of ITP wouldn't be out playing football and being hit by other kids and causing bleeding and, bruising. I mean, swimming, sure. Bowling, okay. But you have to be very, very careful. Now, you would think with platelets very low, oh, just give them some platelets and that will cure it. It's not the case. You have to treat them with the IVIG or the anti-D. It's not just giving them platelets. So what are we going to be watching for? You have a bleeding coagulopathy. That means you bleed easily. You're going to be looking all areas when they brush their teeth. Are their teeth gums bleeding? If they're bleeding and they hit their arm and their elbow, is that bleeding in that elbow? We're going to be looking for GI tract, bleeding out of stool, bleeding out of urine, right? And the other thing is they say with ITP, bleeding coagulopathies, immunizing them for those viral diseases. They don't get the viral disease, they don't get ITP. Makes sense. So, disorders of the white blood cells. Well, what are white blood cells? White blood cells are there, they fight infection. With leukemia, you're producing white blood cells, but they're immature. They don't work, they're nothing. So, we have two types of leukemia. The lymphoid leukemia, the ALL, the easier to treat, and then the AML, myelogenous leukemia, AML. It is the harder one to treat, okay? It is a cancer, and it is the bone marrows just producing these wrong things. And what happens is they don't work, become infected. I mean, a child with leukemia, with a fever, is extremely ill. They can go into septic shock right away. They don't have any immune system. So our priority would get this child some antibiotics as soon as we can, right? So the bone marrow also with leukemia, one of the things that we have to be concerned about is it's the bone marrow, and the bones get weak and they fracture. So you have some more pathological fractures. So what do you see? I had a next door neighbor girl. I mean, usually it's younger kids, but she was, I think, 13 at the time. She went to the ER, didn't feel good. She was pale. She had a pain in her knee and just wasn't right. They took her in, and her white blood cell on admission was 0.1. It should be what, 7? And then over 10, maybe it's showing an infection, but it was extremely, extremely low. You know, the listlessness, abdominal pain, and the lymph nodes are they're trying to do something because there aren't any white cells. So even they get enlarged with this. Sometimes it happens gradually. Sometimes all of a sudden they don't feel well. Remember, with leukemia and blood cells and being formed, you'll always have the liver and the spleen will become enlarged because of the liver involvement. We know that that's where you see the jaundice, that lemon yellow color that occurs because not only the white cells are low, you're going to see your hemoglobin and hematocrit are low, your platelets are low, you're going to see that petechiae and purpura and the bruising. And along with leukemia, you just don't feel good at all. So you're anorexic, you're vomiting, you're losing weight, you're not eating, right? And then because your counts get so low, you're breathing and it's not getting all the oxygen it needs. We diagnose it. Well, just like my next door neighbor with the symptoms, they went and did a CBC and they said, do a blood smear. They wanted to look at the cells and they found the presence of these immature white blood cells. And as I said, her white count was very, very, very low. They're going to look at long bones and the marrow, and they're going to do a spinal tap. They want to see if it's in the central nervous system. Always, you're going to check kidney and liver functions on admission and monitoring it. And we know that what's going to happen is intensive chemotherapy. So the kidneys and the liver have to do with absorption and excretion, right? So those levels need to be watched very, very closely. Sometimes we do radiation, but as I said, most of it is chemotherapy. And what's quite remarkable, the induction part is the first 4 to 6 weeks, where they give these children multiple high dose chemotherapy. And actually, the goal is remission, but they continue on prophylactics and maintenance because there's always a little cell hiding somewhere. So they got to make sure that all those cancer cells are gone. Now, sometimes, even with this chemo, all this chemo and all the things that go on with it, it didn't work. And at that point, a bone marrow transplant is needed. Sometimes we give steroids. What do steroids do? Couple things, right? We know that steroids mask signs of infection, part of it. It causes fluid to be retained, and it causes that big round moon face and little ruddy cheeks almost to the point of Cushing's, right? And it really, these children are already sick. They don't feel well. Now they feel big and pudgy. So it's a lot to do with image that mentally doesn't get them in the right place. Chemo does a lot to the body. I mean, you think of chemotherapy, you think of vomiting, right? I mean, they usually go hand in hand, and hair loss. So again, know that these things are going to happen and prepare them for it. Another thing is the effects of chemo. It does attack some nerves. Peripheral neuropathy. What is that word? Well, think of this. You have nerves that go down your legs to your feet. And then the chemo attacks the nerve and tickles it, and it hurts. It is like an electrical type of pain that happens. And it causes sometimes even decreased senses, could be to the urine, to the bladder. So you're not urinating as well as you should, but also to the bowel. So again, you worry about constipation. So with all these things, worried about body image and urinating and moving their bowels and outcomes and cancer, losing hair, again, have that kid talk to you. Let them know what's going on. And sometimes you have to tell the child, ask me whatever you want. They feel like they can't ask. They feel like mommy has to ask for them. You know, kids that are young understand a lot more than you think. So let them talk. We know with kid with leukemia, there's no anything to fight infection. So as a nurse, washing hands, using masks, using good technique on these children. Also, monitoring their vital signs, monitoring, their lab works. You don't want you already got low white count, watching also those platelet counts. Now, in this case, we would give platelet infusions. We would give blood, probably at red blood cells. And because of all the swelling and stuff and the chemo, making sure we keep that mouth clean and free from sores. So now we're going to go into the digestive system. Now, when you think of GI, it's mouth to anus, everything in between. So what does a GI do? Well, you eat and it goes through the body, it's absorbed, and then you move your bowels and you urinate the rest of the stuff, right? And it gives the body all the food and nutrients it needs. So what would you see when you had problems with the GI system? Well, there are a lot. There's many, many, many. The first thing as a newborn infant, first year of life, one of the things we see with GI disorders is what we call a failure to thrive. And that failure to thrive is that somehow, some way, they're not getting nutrients. Is it because they're spitting up? Is it because of diarrhea? Is it metabolic? What's happening? You're giving them food, they're not eating the way they should. So we need to figure it out. Another thing that's very interesting, somebody who's has pruritus or itching a lot, many, many, many times, it's a liver problem, a liver dysfunction, and they itch a lot. And you can see them very uncomfortable with the amount of itching in the chest, causes vomiting, diarrhea, constipation, bleeding, hematemesis, anything that comes out of the body, mouth to anus, it causes all those things. Now, esophageal atresia. Well, what is an atresia? An A is without. That means the esophagus does not connect to the stomach. So when you eat, where does the food do? It doesn't connect. It comes back up and you vomit. Sometimes with an esophageal atresia, there's this fistula. A fistula is a connection of places that's not normal. Can you imagine swallowing down your mouth to your esophagus, and then there's a connection to the trachea, and it will go down the esophagus, go over into the trachea, and go into the lungs. And that's a tracheal esophageal fistula. How would you treat that? Well, I'm not going to give this kid anything to eat, am I? Normal secretions is going to cause this kid to foam and choke and gag. And that's usually how we figure it out if we haven't seen it in any sort of, prenatal ultrasound. In a perforated anus. Now, would you ever think that their baby's born that didn't have an anus? Do you know I never saw one in all my career? That's one thing I didn't. But what it is the anus was never opening. So the first thing we do at birth is do a rectal temperature. I think the reason is not to look at the temperature, it's to make sure they have an anus, right? Now, they need to go in and do a colostomy. And usually they'll do the colostomy, and through several surgeries, they try to connect it so that by the time they get to, preschooler, there's a way to move their bowels through an anus. There's all different ways they do that. Now, pyloric stenosis, I love the picture of this dad sitting there looking at the baby, and they spit up forcefully into his face. It is really that forceful. And what it is called pyloric stenosis. Well, do you all know where the pyloric valve is in your body? It's the valve that connects the stomach to the small intestines. And what happens, it gets thickened and it closes. So milk bottle or breast can't go down. So the baby eats, baby's happy, stomach is big, and then all of a sudden, daddy looks at the baby and forcefully projectile into his face. If you held that kid up, it would be 12 feet across the room. It is extremely, extremely forceful. Now, what have I seen with these and how do I work with them? I've seen many, 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 many. Very common thing. These children are 3 weeks to 3 months old. Usually that's 7, 8 weeks is where I've seen the most, where the parents come in, tell you that the baby's vomiting. My first question, is it dribbling like a little reflux or is it across the room? If it's across the room, I take my hand up underneath the xiphoid process, little to the right, you're going to feel a hard something. They call it an olive shape. I call it a marble. Doesn't matter, but you're going to feel that hypertrophic pyloric sphincter. So immediately put that kid nothing to eat or drink because they're just going to vomit again. They'll do an ultrasound and then they'll do surgery. And usually they do okay with it. So Mario was nursing well for the first week after I delivered him. Last week, he started vomiting after his feedings, but I didn't think too much about it since he was my first son and had gastric reflux. Okay. This week, he has been throwing up more frequently and he vomits after every feeding now. And sometimes it isn't good. This morning, the vomit flew across the room. There was a little blood in it also, and that's why I called for an appointment. He's usually calm after eating. Now he is so cranky. I'm worried he's losing weight. What do you think is going on? I'm terrified. Very, very common scenario there. It's usually what you hear. Now, why is he cranky? Well, he's not getting nutrition. He's eating, but it's going. So as soon as he eats and vomits, he wants to eat more. Nothing's going down, so he's still hungry. I'd be irritable too. I'm eating, but no, I'm not. It's not getting to where it needs to go. So again, pyloric stenosis, not dribbling, it's projectile. And this is a child that needs to go to surgery. Ultrasound, look at it. They go to surgery, start an IV, give them fluids. Now, celiac disease is a dietary problem. It's all about gluten intolerance. Gluten is in your food. It's in all of your flours, wheat, barley, oats, and rye. You can have rice. Wheat, barley, oats, and rye. What is in those things? Your breads, your cakes, your cookies, breading on chicken nuggets, noodles, pasta, it's everything. You know what's really good today? They've got so many alternatives. And if you even look at some popcorn or not popcorn, but potato chip bag, gluten free, right? And this is why they're getting really, really aware of it. Usually we start to see these intolerances when they start to eat, right? 6 months is when you start to see it. Celiac disease is in the small intestines, has to do with fat absorption and the cilia in there, and it doesn't absorb fat. So what does fat do to the body when it's not absorbed? Fat causes gas. That's why you see that big belly coming up, all right? And then there's actually atrophy of the buttocks that you see. And you are going to have very bulky, greasy, smelly stools. How do you treat celiac disease? Don't give the kids wheat, rye, barley, and oats. Change the diet. When they eat it, they're in severe pain. It hurts. So there's classic, atypical, and there's silent. And the thing about it, it's all type of the small intestines not working the way it should. Those are the different ones, but all of them, we treat it with diet. Now, Hirschsprung's disease, usually we find it a little bit after birth. It's descending colon, your descending intestines that doesn't have nerves in it. So you have a piece of bowel that doesn't know how to do peristalsis, doesn't know how to absorb. It sits there. And then you eat, and even just mucus you're swallowing makes the intestines bulk up and get big. And because there's no nerves, it doesn't hurt. What would you see? At birth, this would be a child who does not move their bowels. Maybe a little bit of something in this tiny little anus area with their little small intestines that hasn't gotten stretched with everything. You might see a little ribbon, like when you take put a cake and put the icing on with those little things, that little ribbon looking thing. Sometimes you see a little of that, sometimes absolutely not. So that's what we call ribbon like stool. And it's more in boys and it's more in downs. And and you can see how big that comes. Now, what we usually do in these children is that intestines is aganglionic, a without nerves. So the food or the mucus or whatever sits there and it stretches because it can't go down. They have to remove it. They take it out. And this is at birth. And they make you a colostomy. Usually by 1 year old, they're able to reconnect it. So they will be having bowel movements, from their anus like normal. But this is what we call a megacolon, a ganglionic megacolon. That means it's impacted, it's not moving. So if we don't treat it, we're having this big megacolon getting bigger and bigger, and it can cause, it to explode and again, shock and infection and all of that. So how do we diagnose this? Well, the first thing we do is just a simple x-ray and we look to see it. Barium enema will tell us how far it is. And if we do a biopsy, we're going to see that there's no nerves in there. And that will be our absolute clue right there. So you remove it. Usually it's about 1 year. They'll take and reconnect it. And from there on, of course, you'll always be watching and monitoring stools, but usually it'll be okay. These children, again, as I said, watching constantly aware. Remember, nutrition, what do we look for? Now, intussusception. This is something that happens, and I've seen quite a few of these too. These are the toddler preschooler area, and it's the intestines is this long tube. Well, a piece sucks up into the other like a telescope, and it causes severe, intense pain. These kids come in crying. It needs to come back out. If we don't, again, it's going to perf peritonitis. It is an emergency. First, we've got to diagnose it. And we're going to diagnose it by sending them to ultrasound. In this case, we might see what we call a sausage-shaped mass. You're going to see that double intestines, usually in the right upper abdomen. And again, if it's in there and it's stuck and we catch it on ultrasound, they'll do either an air or a barium enema to try to open it up so they don't have to do surgery. I've only seen actually one that had to go to surgery and they had to take out that piece of intestines and then reattach it. Hernias are common. I mean, how many of you seen umbilical hernias? You like to push them in and out, nice and squishy, right? That's what you want to see. If we see it hard and painful and reddened, that's when these children, their intestines have switched and, turned, and you're worried about no oxygen getting to it and that tissue will die. So a soft one, it's not a problem. Intestines is still working, but again, you're going to worry about it getting to the point where it's hard and painful. So a nurse is conducting teaching and discharge planning for the parents of a child who's scheduled to undergo surgery for a gastrointestinal disorder. What should the nurse tell them? What do you need to worry about postoperatively? GI problem. What do you worry about?
Bleeding?
Worry about eating?
No, bleeding.
Oh, absolutely. Bleeding for sure. We're worried about constipation, diarrhea, with peritonitis, infection. And again, then making a diet as the child gets older, keep that intestines moving so it doesn't clog up. So we don't even worry about, it perforating later on in life. Again, GI is keeping it moving and keeping proper nutrition. So gastroenteritis. One of the most common things with kids is because everything's in their mouth. They're always having vomiting, diarrhea, which it is common. It's gastroenteritis. Itis is an inflammation, either the stomach, the intestines, whether it's both. Sometimes it's due to infection. Sometimes it's just due to, food intolerance. In fact, it's one of the things you look for when you start feeding newborns at 6 months old, right? If they start having GI problems, probably don't like that food. It's an intolerance. Should never overfeed the kid. And then how are you fixing that formula? Are you fixing it properly? Are you using good technique? It could get bacteria in there. And then that sorbitol is one of the things that we don't like to give a lot of. And there's certain meds that have it in there. One of the things with whether it's diarrhea, vomiting, our biggest concern always is electrolytes. When you vomit, you have diarrhea. What do you lose? You lose a lot of potassium. And then, of course, young kids, if they're not eating and they're vomiting, you always worry about glucose, right? They don't have enough sugar in their body. So vomiting is something that happens where acid from your stomach comes up and you vomit it out. One of the base problems that happens is you're vomiting acid, right? So what are you left with? There's no acid, so you're metabolic alkalosis. It's the opposite. When you have diarrhea, it's alkaline coming out. It's all the enzymes that help with digestion of food are alkaline. So what is left? With diarrhea, metabolic acidosis. So think about, the stomach and the intestines, they're opposite from each other because everybody knows there's acid in the stomach. If it's gone, what's left? It's only alkaline. What causes vomiting? Well, feeding too much, not burping. Um, also remember anything with increased intracranial pressure, headaches, all of those things do cause vomiting in children. And remember, if they're vomiting, they always have a risk for aspiration. Reflux, very common in newborn children. And even as they get older, they just don't tolerate some foods and they spit up a little bit. Again, it could be something to do with food intolerance. Remember, with gastroesophageal reflux or GERD, there's many ways to treat it. Smaller portions, not overfeeding, sometimes medications, burping right, sitting them up after feeds. All of these things can help decrease that. Diarrhea, again, we're always concerned about all the electrolytes and the fluid that we're losing. So we know if all of a sudden they start with diarrhea, something caused it. Was it food, an infection? Was it medication? Or did that kid get into something, some poisoning, something we look for? If it's going on and on 2 weeks later, remember, they're not getting food, nutrients. So we need to worry about that malabsorption problem. And we know diarrhea can be just viral, which is most common, but it could be bacterial or parasitic, where then we have to treat it with medication. Now, one of the things about constipation, believe it or not, it's one of the only things kids can control is their bowels. I can't tell you how many children come in, the parents tell me, my 2-year-old has not moved their bowels in 10 days. And I'm like, 10 days? They go, no, has not. And we're absolutely positive. Sometimes children control their stool because something's going on and they're stressed and they want to have attention paid to them. And I've seen that. Sometimes when you have constipation for other reasons, what we'll see is something called encoparesis, where they're constipated, but some of the liquid comes around and they soil themselves. Okay. One of the things that we do not do with children is put them on daily laxatives or enemas. We try to treat them naturally. Now, they come in, haven't had a stool in 10 days. We see the big stool in the x-ray. Yes, we'll give them an enema and get it moving and get that big stool out. But after that, diet increasing fluids is what we do. We do not like to do that because you put them dependent on laxatives and enemas as a child. Can you imagine by the time they get the adult, there's nothing that can help them go. So fluid and electrolyte imbalance, I've measured it a couple times. Remember, dehydration in children is dangerous. They can go into multi-system failure through it. So it's something we really need to be aware of, okay? We know that the body, just by fever, loses, and lungs, breathing, we lose water in so many different ways. Sweating, and when all these things happen, we're losing fluids, losing electrolytes. And there's different things in what we call dehydration. Isotonic means that you've had water and electrolytes both getting lost. When you're left with hypotonic, this is when you don't have those electrolytes. That means less than the stuff you need in there. Hypo, less than. Your potassium, your sodium, they're going to be low. And then hypertonic, you're dehydrated, but your levels are high. So isotonic, hypotonic, hypertonic, it depends on what it is and what fluids we give. We know usually you have a child dehydrated, we're going to be giving them some boluses of normal saline fluid, right? If they're younger and can eat, maybe Pedialyte, Gatorade, one of those things. So an infant's admitted to the hospital related to gastro and vomiting. The nurse observed the infant's mother immediately placed the child flat in the crib after a feeding. What would you do? They just ate, put him back in the crib. Is that a good thing? They're going to aspirate, they're going to vomit, and probably choke on it, right? So always these young, and this is infant, that means less than 1, burp them well, sit them up, let them have a chance to, get used to all that fluid they just put in their belly. Overhydration does happen for many reasons. The body's getting more fluid that can go out, and you're going to see fluid in different places. Interstitially, eyeballs are a big one that we do see it in, and you'll see them big and swollen. What happens a lot, it's that the blood doesn't have enough protein in it. And when it doesn't, the blood, the liquid goes interstitially. So sometimes it's just by correcting that um, protein, albumin is the other name for it, and it pulls the fluid back in there. So protein is a big thing with these swollen eyes and things that we're seeing, and that over, fluid that they're seeing. Anasarca is generalized everywhere you're seeing swelling, and that's the term. Nutritional deficiencies. I've already mentioned, failure to thrive. And we know it. Sometimes it's because the kid's too tired or weak to eat. We talked about congenital heart defects, right? They're working hard just to get oxygen around, and the body's not functioning normally, and the body's tired and doesn't eat. And that can make a child, have a failure to thrive. I mean, we would do different things to get better nutrition into that child with less liquid, like increasing calorie counts, right? And then sometimes it's what we call a non-organic failure to thrive. And that's because the kid is not getting enough to eat. The parents or caregiver is just neglecting them. They're not eating. I've seen one case like that on one child. And the kid looked about as skinny as that one in that bottom picture. So, what happens when you don't get nutrition? Failure to thrive. First of all, it's cognition, right? Growth, development. They're not meeting milestones at all. They're underweight. I mean, it is dangerous not to give nutrition to a young infant. They don't get what they need. Their brain's not functioning, and they're going to have problems through the whole thing. So appendicitis, you think of appendicitis, you think right lower quadrant, right? With Bernie's point. And the appendix is that little thing connecting the small intestines and the large intestines. And it is, it's at the cecum. And usually kids come in, you see them bent over, holding their right lower quadrant, and you're seeing them limping on the right leg. And you could tell that's an appendix. So it is very painful, and it needs to have surgery as soon as we get it. Thrush, oral candidiasis, or ungo is the Spanish, and it is a fungus, and it hurts, and it is painful. So we need to put medicine on there that's for thrush, mycostatin, nystatin. And in infants, remember, we're going to take it and swab it on with a Q-tip usually. We don't just squirt it in there. We want to get all those white areas to take care of it. If they're breastfeeding, make sure that they clean their breasts. If they're bottle feeding, make sure those bottle nipples are really clean in between. And usually in a couple days, it's fine. Worms, very common in kids, right? Go outside, play in the dirt, their nails are too long, everything in their mouth, and there goes eggs. And now we have a child who at night's complaining of anal itching and tickling. And it's sometimes these itsy bitsy, like the size of a rice kernel, and even thinner than that. And what do? Well, when we're suspecting it, we tell the parents in the middle of the night when it's dark, take a piece of scotch tape and a flashlight, go in, put the tape on their anus, and you'll see the tiny itsy bitsy little worms. Put it in a container. We could bring it in and show the doctor what it is. And what they do is we do give medications for that. Very common. Remember, it is contagious. The whole family should be checked. Roundworms are bigger worms, okay? And this is unsanitary disposal of stool and just general poor hygiene. And again, this is a kid who's outside, nails are long, in their mouth, again, same sort of thing. And what happens though, they get so full of worms, they're going to see a cough because of the worms that are in there. It keeps tickling them. Again, we can treat that. Every parent should have this number by their bedside, the help number for poison control. I mean, if you take a child to the ER with a condition like they swallowed the whole bottle of their vitamins, or they swallowed, some one of those Tide balls, in their mouth, and they come in, we do our vital signs, weight and whatever, make sure they're breathing, etc. We're going to call poison control. What is the newest up-to-date treatment for it? So our goal with it is to make sure that what's in there, that they don't absorb too much. Now, we never, ever, ever recommend vomiting. We don't give Epicac anymore. No. That's why we say to parents, if they've swallowed something, call poison control. It could say, have a glass of milk, or have a bread or a toast, or there's all different things to prevent them from absorbing. And we know when they get to the ER, it might be drinking charcoal or putting an NG tube down, depending on what has gone on with them. The most common thing that I've seen, I can't even tell you how many children, what they eat. The most common is their vitamins. And you know something? They're not hurt by it, because vitamins you don't need, your kidneys just excrete. What the dangerous one is, Tylenol, because Tylenol causes hepatic toxic poisoning, right? So thank goodness it's the vitamins. Lead poisoning. Think about an older building. I mean, a lot of areas don't have it, but some do. What do kids do? They go up to the windowsill, and now they're 15 months old and they're teething. They sit there looking out the window and chewing on not getting is the paint, which could have lead in it, and it could be extremely dangerous. So, if they eating this lead and we don't get them out, get it out of them, which could be by an oral iron chelating medication, or there's something like a dialysis called an apheresis, and it combines with the iron and they just excrete it. So we can get rid of it. Now, if we don't, iron causes severe mental retardation. So we really need to get it out. And it's a long lasting effect on them. So eating non-food items is called pica. And you have some people who just eat crazy things, toilet paper, and I've seen plaster, and all goes on and on. Foreign bodies. Well, everything's in the mouth, right? That's why we always say kids less than 3, no small items around them. Well, I'm telling you, this picture, and that's a quarter, most common thing that the kids have in their mouth. It's not a dime, it's not a penny, it's always a quarter. And that picture, it's always right there. I mean, this is the classic picture of it. They come in and they're usually fine sitting there, but we need to get it out. So they come in, their airway's good, send them an x-ray, we get the picture. The surgeon actually comes, puts a Foley catheter down their mouth below where that coin is, blows up the balloon on the Foley catheter. And they're sitting on the surgeon's lap with the child facing outwards. They bend them over and they pull the Foley out, and the quarter usually comes with it. And they spit up a little bit. Older kids, I would tease and say, if I get the quarter first, it's mine. So it comes out and they're on the floor trying to get their quarter. So sometimes we say, all right, it's already in the stomach, let it pass. And then they'll come back in a day or two and we'll do x-rays. That's the other thing. But if it's stuck up, right there, we're going to do something. So a father brings his 2-year-old child to the ER. He's holding an empty bottle of aspirin and tells the nurse they're 10 325 milligram tablets. How should the nurse respond? What did I tell you about aspirin? Aspirin probably one of the most dangerous things, right? Bleeding, it is dangerous, and do your vitals, and we're going to be calling poison control. One of the teachings as nurses is making sure that all medications are somewhere where kids can't get into, whether it's a locked box, depending on what medications, mom or grandma's on, making sure they're not in reach of the kid, because kids get into everything. Any questions? Well, we went really over on that today. So I really do not have time to do the codes. It's 30 some odd questions. I will send it to you so that you do have it there. Any other questions you have? So remember, next week, no quiz. We're going to do that week 10. So I'll be posting something for Tuesday next week or Thursday, depending on what Professor Stiles says. And I'll get the review, knowing that I always post everything. Also, like you said, and you wanted, I'm going to start posting a lot of SE stuff so that you're going to have the PowerPoint and the codes, and you can start working on that and be prepared. So you'll have that at your access. Also, anybody who's suffering with math, please meet with me. Christian can tell you, I could teach you pretty quick. Look at the review that I have on YouTube. Come to me and we'll make it easy. It's actually fun and easy when you just figure out a couple steps. That's how I make it done.
Okay.
You all have a great weekend. If you need anything, I'll be on the beach watching an air show. But if you need anything, I'll always answer my messages. You guys have a great weekend.
Thank you. Happy
You too.
Memorial
Have a
Day
good holiday.
weekend.
You
Enjoy
too,
your
guys.
son.
Thank you. Have a nice
Bye.
Enjoy.